All right, there you go.
So, hi people, hi friends. I'm so happy to be here. I know I've been like in my couple of weeks now, and it's always really fun to see all of you guys here. Today, we're doing our very own special VMR with people all over the world, and it's dedicated to people who speak English as a second language. The way we've been doing it is that we only need a case presenter. So somebody please volunteer. We'd love to hear your case. And then we are going to learn from everybody in the chat. We're going to be discussing it through the chat, and everybody can say their opinion. And then if you want, you can share it out loud. And yeah, that's it. Hope everybody's as excited as I am. And I don't know, today, Travis, we have the amazing Travis here who's going to be scribing. I don't know if you want to introduce yourself, Travis.
Yeah, certainly. You able to hear me? Perfect. So happy to be here. This is actually the second time that I've been on this, and the last I fell in love with the format, and like I have to come back. You know, coming here and just going through the chat. I feel like most of the time I spent myself, in the chat and sharing links and knowledge and learning from everybody. But having the ability to kind of just listen to everyone, go through their thought process on everything is such a wonderful um, way to learn, and just learning from all you guys. I feel like I've met so many people through Twitter and on here from all over the world, and just learning from everybody is just wonderful. And yesterday learning from Tiago in his case was amazing. And I never thought how much I would learn as an ER physician about testosterone and PCOS and how I can apply it. But you always take those little nuggets, and you never know what you'll see in your next patient, and trying to help them out and guide them to where they need to go. So even though I practice emergency medicine, learning all these things from all of you guys is very helpful in my pursuit to learning as much as I can. So thanks for having me.
Amazing. Sukriti, do you want to say hello, and then Kiara?
Hi everyone, I'm Sukriti and I'm calling from India. So just looking forward to seeing all the Hindi in the chat and all the Spanish and Portuguese. And I think if Kiara is there, I'll let her introduce herself.
Hey friends, I'm Kira, medical student from Peru. And I forgot to tell you that Gabriel has a case, so we have a case.
Oh,
And yeah, I'm so happy to see you all.
incredible. And I see Gabby here too. Gabby, good morning.
Hi, good morning, everyone. Nice to see you all here. I always learn so much with you since I'm a neurologist, and I learned so much about internal medicine and infectious disease with you. And actually, you can make everything so fun and so easy to learn. So I'm very grateful to be here.
Good to see everybody. I also see Hernan's daughter is here. Wow. She brings the music and then the family. Look at that. Like, how can we ask for more? Her name is Isabella. Hello, Isabella. Good afternoon.
Hi, everyone.
Hello, Hernan. How are you, my friend?
Very good.
Wonderful.
Happy to be here.
A delight to have you. Your episode has been really, really, it was amazing. And hopefully we'll get it on the podcast very soon. I think in the next month or so. Anne Marie, I see you posted something in the chat. Do you want to just throw in a quick plug?
Hi, everyone. I'm so excited to just get to observe the amazingness that's going to happen today. But if you could please try to fill out the CP Solvers feedback form, I posted the link. It's just a great way to improve the amazing things the CP Solvers are doing every day, and also submit your ideas for ways for improvement.
Amazing. Thank you all. It looks like Gabrielle has a case for us, which gets me very excited and very nervous. I will tell you that my sort of like cultural thing of the day is yesterday I had a very interesting lunch. I had leftover mac and cheese from the day prior, classic American dish, just cheese, shit ton of cheese, like a lot of cheese. And I don't know what the mac part is, something. And I also had this Lebanese delicacy called mjaddara. Mjaddara is this lentil and rice-based dish. And within it, I had the extremes of culture, you know, East and West, but I also had the extremes of health with very unhealthy mac and cheese and then very healthy lentil-based dish. And I was like, which one am I going to have? Am I going to have the mac and cheese or am I going to have the mjaddara? And Maria, what do you think I did? Come on, it's easy.
You had both.
Heck yeah, there we go. In life, all problems come down to one thing. When you're deciding between or, just make it an and all your problems will be solved. So take your ors and make them an and. That is my life advice for today. Make your ors and make them an and. So instead of just having my tea or hanging out with you, I'm going to have my tea and hang out with you and hear a wonderful case from a dear friend, Gabrielle. Please unmute yourself and reintroduce yourself to the team and we'll jump right in.
Hi everyone, my name is Gabriel. I'm very excited to be here today with you guys. I always love these VMR sessions. And in case no one knows, I'm from Peru. And what I love about Peru is the culture here. We are a very diverse country. We have a lot of climate for beaches, jungle, and even the highlands with snow. And it's very beautiful here.
Oh, you make me so. Oh no, sorry, I didn't mean to interrupt you.
No, I was about to say, if maybe would you want to start with the case?
Well, I want to thank you for taking us through a quick virtual journey of Peru. I really hope I get to visit you, Kiara, and many other friends from there. That sounds absolutely magical. Before we jump into the case, I have a live update. The mac part of mac and cheese is macaroni. For those of you who already knew that, which is like 99% of the audience, thank you. Anyway, Gabrielle, yeah, totally take it away. And as a reminder, the whole goal is to get as many voices as possible and for all of us to learn from each other. So please, please, please type in the chat and be ready to jump on in. If you don't want to participate and just want to stay in the chat, just say, I'm going to, no thanks, Robbie, I'll just stay in the chat. That's totally okay. But the whole goal is to have everyone heard. So Gabrielle, take it away.
Yes, I would like to start the first aliquot with an image. I think an image speaks more than 1,000 words.
Yes. I'm going to make you 1 second. Okay, you can now share your image, my friend. Go for it.
Thank you.
I think it's taking its time. I'm going to give it a little bit. Yeah. There we go.
So the first big concern is a 60-year-old woman with necrotic distal finger lesion.
Hello, Kiara. Good morning, good noon, good afternoon.
Hi.
Be here. What do you see? What is it?
God, I don't like images. So I just read something interesting previous day. This is called Berger syndrome, I believe, but it is more common in men who smoke. So they can have like distal necrosis or like some kind of vasculitis. And this is kind of some sort of presentation. Also, this is like one small thing, right? But if I have to see the broad picture, this is like some sort of ischemia. So we can have ischemia for many causes, like septic shock or any kind of shock. So it represents like distal parts of the body. So
amazing.
Yeah.
Okay, let's break this down. I absolutely love that. And you can see when you look at the chat very quickly that Kirtan and Kanu agree with you that this is likely a vascular event. Hans is jumping in with another thought. Hans, do you want to just tell us more about what you're thinking?
That was just a thought, and I'm not sure whether there are bacteria that can cause necrosis, maybe because of underlying inflammation that comes as secondary.
Fantastic. I absolutely love that thought. And Valeria is thinking of another thing. Valeria, do you want to tell us more about your thinking?
Yes, I am actually totally biased because I saw a similar case a couple months ago. And I think autoimmune hemolytic anemia could cause, I mean, I think it's peripheral ischemia,
Yes.
so cold, and just made me think of the possibility of autoimmune hemolytic anemia by cold antibodies and also something ischemic or vascular that could also, as Kara said, Berger syndrome is super interesting. And yes, as Kirtan just mentioned, cryos could also explain the location.
Yes, and I believe the CAD abbreviation is not coronary artery disease, but cold agglutinin disease. Kirtan, do you want to unmute yourself and just expand on your thinking?
Yes. Yes, sure. I mean, whenever I think about the possibility of some necrosis in the distal digits, I think about whether we are dealing with a problem with the blood itself or problem with the blood vessel itself, right? So we can break it down anatomically, and then we can think that if it's indeed a problem with blood, what is the problem with blood? Are we dealing with the hyperviscosity issue? Is the extremities getting cold and that's why you are getting congestion there? So we know that cryoglobulinemias can precipitate in the cold and peripheral environments, and then cold agglutinin disease, paroxysmal cold hemoglobinurias, all the entities which can be manifested by IgM levels, like let's say Waldenstrom's macroglobulinemia, CLL. So all those things can cause peripheral ischemia. And then about the blood, you can think about embolic lesions too. What if the patient has endocarditis? What if the patient has embolic showers throughout the circulation and it just happens to hit one of the fingers now? Maybe it will hit toes next day. Maybe it will hit another organ next day. So it is one of those things that we have to consider. And lastly, some rare entities, and we can talk about the vascular war itself. What if it is indeed a vasculitis, like Raynaud's or secondary Raynaud's, due to underlying connective tissue diseases like systemic lupus erythematosus, systemic sclerosis, mixed connective tissue disorders, and all the rare vasculitis like polyarteritis nodosa, cryoglobulinemic vasculitis. So we can break it down anatomically, and then we can see how the data comes in. And let's see how we can zoom in. Can you help me, Rabi, how to zoom in on those possibilities?
Absolutely. I have to tell you, I'm trying to help you, but I'm distracted by the beautiful rose in Hernan's left ear right now. It's magical. Hi, Isabella. Sorry, I was going to say something else now, but I completely forgot. Oh, Kanu has a great list of mimickers of vasculitis. Tell us more what you're thinking there, Kanu.
Yeah, so Kirtan already mentioned that you can divide it into blood and blood vessels. Yeah. So I think I will expand on this, that things like Waldenstrom's or other paraproteinemias, they can cause increased viscosity in the blood, and that can also block the vessels in a way, and that can lead to ischemia. The other things like leukemia, as you mentioned, can also, if there are a lot of leukemic blood cells flowing in the blood, that can also clog the blood vessels. There was a recent article I read where there was a patient who went blind because of increased leukemia because it blocked his optic blood vessel also. So like those things are certainly possible, and I think we cannot, those are rare causes, but I think those should be concerned also.
Beautiful. Absolutely brilliant. I completely agree with you. Folks, I'm going to be very honest. I looked at that image and landed in a slightly different place than the conversation we're going. And you know, I'm really curious. I think this highlights a really important principle, which is that all of us are going to be thinking probabilistically right now, and whether the sense that the collective, the sense of the collective group is a little bit different than my impression. We'll see. Both of them are very probable, but here's where I landed. I landed of, oh, you know what? I know there is necrosis here. There's definitely necrosis. And there's a big important caveat. And that caveat is ischemia and necrosis are two fundamentally different concepts that have some overlap. Ischemia implies that necrosis is a result of vascular insufficiency. So if you look at that image, you're like, there is necrosis for sure. And the question is it ischemic necrosis or non-ischemic necrosis? Now, what else, first of all, can cause non-ischemic necrosis? Think of cavitary lung lesions or brain abscesses. Non-ischemic necrosis can result from pretty bad infections. Non-ischemic necrosis can also result from autoimmune diseases. Classic example, pyoderma gangrenosum. Non-ischemic necrosis can also result from infiltrating or aggressive tumors that eat the tissue away. Non-ischemic necrosis can also result from infiltrative diseases that eat tissue away, like amyloidosis or mastocytosis. So necrosis and ischemia are separate concepts but closely related because ischemia is the most common cause of necrosis in general. So when we look at that image, we're like, how could it not be ischemia if the base rate prioritizes ischemia as the cause of necrosis, and that ischemia tends to have a pattern, and that pattern is distal involvement. So you look at something, you're like, there's distal necrosis, how could it not be ischemia? You have to balance that with the other variable that we saw here. Gabrielle, do you want to share your image one more time? So I'll just look at this, folks. There is a law of proportionality. And the law of proportionality is grossly violated here. Why? When one finger is so diseased, it's gone. And look at the beautiful pulp on every other finger. You can make the argument that there's a selective vascular involvement in that finger because of an embolic issue or thrombotic issue, but you have to stop and be like, wait, yes, this is distal necrosis, therefore ischemia, but you have to ask the question, why is every other finger spared? And not just spared, they look pristine. They don't even look dusky or blue or dark. They look like they're freaking so well perfused. As perfused as much cheese I had on my mac and cheese yesterday, like oozing in perfusion. So why? I don't know. Does that help us prioritize non-ischemic necrosis? Does that help us think about infections? I don't know. We'll see. But pay attention to that. Your tendency is to say necrosis equals ischemia, especially if it's distal. But you have to stop and be like, is there non-ischemic necrosis? Is it an infection that's causing a cavitary skin lesion, like a cavitary brain lesion, so on and so forth? And of course, the next key step will be distribution. If we see multiple fingers or toes like this, we're done. It's ischemia. But put the brakes on for now and just call it necrosis until there's more evidence to call it ischemia. That's my advice. But we'll see. It may be premature, but there's too much sparing of the other digits here to commit to a vascular problem right now, I'd say. Alrighty, back to you, Gabrielle.
Hey, Robbie, can I mention one thing? Kanu mentioned something about the toes.
Yes.
And I think we all look at the toes are usually the most common, digit, fingers, toes affected in the base rate of, diabetic vascular disease. When it's on the fingers, something else is going on here. It's less likely to be that chronic progressive, vascular injury that diabetics get. And you have to kind of look at some of the other, mimickers that you had mentioned, versus, is the patient a smoker? I think that brings in a lot of other kind of compounding factors. And Hans mentioned infection too. There could have been distal trauma there at one point in someone who smoked and had some other predisposing injury. I had a lady about a month ago who got bit by her pet schnauzer on her finger, required some stitches. She came back, it was black and necrotic. The culture grew Pasteurella canis, but she was a smoker, she had an injury, and her fingertip was necrotic and probably needed to be amputated. So there's so many things to look at, but I definitely would look at the toes. And it was awesome to see Kanu bringing that up.
That's a brilliant point. You want to try to get the center of gravity of disease, and now we're all assuming that it's just that finger, but a lay of the land will help us reprioritize that, no doubt. And especially the toes where we may not look because the socks are on or the shoes are on, for sure. All right, Gabrielle, give us more.
Awesome discussion, guys. So the disease started 3 months ago. 3 months before the necrosis, the necrosis of the finger, she refers generalized weakness and progressive dyspnea. And during the course of the disease, the patient refers that she was extremely sleepless during the day. And 7 days before, she notices bluish discoloration in her finger. So she decided to come to a local hospital, but the doctor told her that it was just a temperature reversible effect, and she just needed some warm and used gloves. But the patient wasn't comfortable with that recommendation, so she decided traveling to Lima, to the capital of Peru, to consult a better physician. And in family history, non-social history, she used to smoke 2 cigarettes daily, but she quit smoking 10 years ago. Social alcohol history, social alcohol intake, she has social alcohol intake, but no other recreational drugs, and she has no allergies. Is there something maybe you would like to know about the patient?
Amazing, Igor. Maybe we can have you share your thinking here, and then we'll see what questions folks have.
Mm-hmm.
Hello, everyone. My name is Igor. I'm a second year internal medicine resident here in Brazil. And what I'm thinking about the case is now there are more systemic symptoms that we didn't have before. There's dyspnea, there's weakness, and there's a history of a bluish discoloration of her finger that brings a renal phenomenon back to the table. I believe someone else talked about renal phenomenon before and brought up the difference between primary and secondary renal phenomenon. I believe these systemic symptoms may lead us to think about a secondary renal syndrome. So I would like to lead this way of my reasoning.
I love it. I think it's superb, honestly, and I completely agree with you. Kanu, can you tell us more about levamisole? What do you know about it?
Honestly, apart from Steph, I don't know much about it.
No, but tell us what you know.
But when I was doing my rotations in the United States, I actually saw a case where a person who used to take cocaine actually developed vasculitis, like a similar picture here. But then his cocaine test came negative. And then we actually found out that it was actually adulterated with levamisole, which caused the vasculitis here, and which caused the gangrene of his fingers. So that's why I pointed out.
100% brutal. Thank you so much for bringing it up. Levamisole is notorious for causing a primary cutaneous vasculitis with propensity for the acral surfaces. And the clues are, of course, potential exposure to cocaine, which you may be talk to the patient or see on exam through nasal deformities. The curious thing about levamisole is 2 laboratory features, but often accompanied by neutropenia, which is a unusual thing. And most patients have a positive, very high titer p-ANCA antibody, which is really, really interesting. So it's like a drug-induced ANCA vasculitis. Amazing. All right. Trying to scroll the chat for any further information, maybe because I just realized we're halfway through the hour and I know there's a lot more coming. So I will say, I think now what you can do is you start to say necrosis is much more likely to be ischemic because of the presence of bluish discoloration, which maps on very confidently to a vascular phenomenon. That has to be tethered and balanced with the fact that it's still only one finger that we got, that one finger feels bluish, which is unusual. But I think we have to proceed with the idea that this is a vascular phenomenon. The question is it something in the lumen, like a thromboembolism, or something in the wall, inflammatory or otherwise? And, we've talked so much about dyspnea and weakness. And as Igor was saying, now this is a systemic flavor. And I'd say we're probably going to ignore the weakness for now because it's much less specific than the shortness of breath. And we'll see where the shortness of breath maps us. I would say we're probably pushed in both directions of the common causes of shortness of breath. The evidence for heart disease is that the heart is part of the vascular system. And so if you have dyspnea and you have a vascular problem, you're much more likely to invoke the heart with thromboembolic cardiac disease. But then the balance is, as Igor was saying, Raynaud's, autoimmune, and the autoimmune diseases are much more likely to affect the lung in the form of ILD than they are to affect the heart. So you could make an argument that the heart is in consideration because of the vascular phenomenon, or you could say vascular equals autoimmune, as Igor mentioned, which takes us to the lung. So we'll see where that complicated story plays out. All right, Gabrielle, give us more, please.
Yes. So in the physical exam, the pressure was 170, heart rate 110, respiratory rate 18, temperature 36.5. In the physical exam, it was notable of the fourth left finger necrotic lesion, and when the feet, when the feet were examined, there were compromise of the second to fifth finger of the feet, similar to a distal necrotic lesion. No other fingers were involved. No lymphadenopathy, cardiovascular. The cardiac sounds were rhythmic, no murmurs. Pulmonary exam, it was clear to auscultation, and abdominal exam, it was not noticeable for splenomegaly. Neuro exam, the patient had a normal motor and sensory exam. She looks orientated. And maybe I could give you some basic labs. Okay, so hemoglobin was 5.4, leukocytes segmented 60%, bands 2%, basophils 2%, eosinophils 5%, monocytes 2%, and lymphocytes 31%.
Gabrielle, not to interrupt you, did you say the hemoglobin was 5.4 or the white blood cell was 5.4?
5.4 hemoglobin.
Okay, got it.
What was the total? Sorry.
Sorry, I don't have the total. I missed that. But it was a normal count, the total white blood cell. And platelet count was 170,000. Mean corpuscular volume 98. Median corpuscular hemoglobin 29, sorry, our median corpuscular corpuscular hemoglobin concentration was 30, and creatinine was 0.6.
Could you copy some of that into the chat for me?
This choice.
What was the MCV?
98.
I'm not going to pick on anybody, but only to add in a thought. So, Valeria, you were already thinking a long time ago about hemolytic anemia, and now we have an anemia. We don't know it's hemolytic, but how are you thinking about this now that your idea is gaining a lot more momentum?
I mean, I think it was just pattern recognition actually, because I had read about this type of presentation, but I think, I mean, the distal lesion in the hands makes me think, as you brilliantly explained, Ravi, of ischemia, necrosis, and I think hemolytic anemia is one of those things that could be rare by cold autoantibodies. So it's always something that I have in my mind just because I always forget it. I'm not sure. I mean, I would like a full hemolytic panel just to rule it out. And I mean, the risk factors that this patient could have to develop that type of hemolytic anemia, maybe it's part of another systemic syndrome or autoimmune disease, or maybe post-infectious cause like mycoplasma, I believe, is associated with cold hemolytic anemia.
100%. I'm right there with you. I think it's hard not. when we study a thrombotic disorder along with anemia, it's hard not to say, well, anything that causes thrombosis is likely to cause anemia of chronic disease. But the depth of the anemia here argues strongly against anemia of chronic disease being the sole contributor. If you have anemia of chronic inflammation or anemia of chronic disease, the hemoglobin very rarely goes below 9 or 10. So it's almost impossible for the anemia to be of chronic disease alone. And when you marry that with the splenomegaly, it's hard not to say, okay, there's a hematological dimension to this case that appears to be very, 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 very robust. And I saw Hernan had some great thoughts about relating this to the tobacco exposure. So Hernan, can you expand on that if you don't mind?
Yes, thank you. I think until this moment, we have an anemic syndrome of chronic course that is with an ischemic and a necrotic phenomena in a tobacco consumer female. So we have to think that the anemia is severe, but the other parameters are in the context of normal anemia. So that could be that we have to think, for example, that could be an hemolytic anemia mixed with a phenomenon of bleeding, of chronic bleeding. And for example, and that the necrotic phenomena is in the context of a vascular disease in the context of tobacco. That could be an explanation of the case.
Absolutely brilliant. I couldn't agree more with you. I think that completely stands on its own. I will say that when you see something, anemia, and you see thrombosis, how could they be related? They don't have to be related. They can be true, and unrelated. This person has chronic iron deficiency anemia as a new cause of thrombosis. One thing could be causing the other, or there's an underlying thing that connects both. And if we do the mental exercise of saying what disorders that cause anemia directly cause thrombosis, and if let's play around with that in the chat. So if I say, like, how can you connect a cause at the bottom that causes both thrombosis and anemia? And I'll share the thoughts from the chat. So Kanu is saying malignancy, either leukemia, causing DIC for sure. What other thoughts can we think of? So yes, Raphael's thinking of microangiopathic hemolytic anemia, APLS, autoimmune phospholipid syndrome, a lot of the MAHAs for sure. PNH, absolutely. Yeah, I think that the short list is MAHA of any kind, including DIC, HUS, catastrophic antiphospholipid antibody syndrome, PNH, paroxysmal nocturnal hemoglobinuria. Kushal mentioned sickle cell disease for sure. And I'd also add cold, as Valeria mentioned a long time ago, cold autoimmune hemolytic disease. The IgM antibodies are prone to precipitating in the peripheries and causing thrombosis. Now, which one of those causes splenomegaly? I think the presence of splenomegaly here without leukopenia or thrombocytopenia would make the malignancy hypothesis, a liquid malignancy hypothesis, very plausible. But I'd say the next steps are to look for that autoantibody that Valeria was suspecting a long time ago, the serum protein electrophoresis, and to work up this anemia. If this anemia is hemolytic, that'll help us filter down the next case. So I think the center of gravity is thrombosis, splenomegaly, and anemia. And if we understand the anemia better and call it hemolysis or call it anemia of chronic inflammation or whatever, we'll make a lot more progress. So I'll give the mic back to you, Gabrielle, to give us more.
Hey, Gabrielle, was there lesions on the toes, or I thought you had mentioned
on the second to fifth toe. I mean the second, the third, and the fourth, and the fifth. Yes. Sorry. I wrote in the chat no toes because I thought toe referred in English to the first toe of the foot, but I think toe is all like the fingers of the feet. Just a translation problem. But yes. Is there something you would like to know? In this aliquot, I will show the peripheral smear. Okay, let me share my screen. Okay, so the reticulocyte count was 28%, total bilirubin was 8, and indirect bilirubin was 6.2. Lactate was 850, and this is the peripheral smears. It was there are some reticulocytes, a normal blast, the direct Coombs was positive. Serology for hepatitis B and hepatitis C was negative, and ANA negative and ANCA negative. And the next aliquot will reveal the final diagnosis.
Amazing. Maria, so you came to the conclusion of hemolysis. How did you do that?
Yeah, this is great because I remember the first case I actually discussed. I didn't even know what it was hemolysis. Like I couldn't recognize it. So now I know that, very rapid anemias or like very low hemoglobins like we see here. And then, with the labs, we have a high LDH, a high indirect bilirubin. And then with peripheral smears, I actually can't read anything out of them, but I think there was like spherocytes. That could also mean hemolytic anemia. And then with like the Coombs, which is like a reflex testing for hemolytic anemias, that was positive. So now we can add like another name to it, which is like autoimmune hemolytic anemia. And then, yeah, I think that's what I got from that aliquot.
For sure. The diagnosis of autoimmune hemolytic anemia is really centered around the Coombs test. And the Coombs test is positive in 95% of patients with autoimmune hemolytic anemia. And the spherocytes are present in about 50% of cases. So it's plus minus. And here we have both. So I think we squarely landed on the diagnosis of autoimmune hemolytic anemia. And I'm curious how the chat, like how anyone in the chat breaks that down. So when you know the patient has autoimmune hemolytic anemia, how do you further break that down? I'll scroll to see what thoughts folks have. Yeah, so people are really confident that this is autoimmune hemolytic anemia. Yeah, maybe I'll just jump in for the sake of time to tell you that we typically divide autoimmune hemolytic anemia into two categories. There are ultimately actually four. The two categories we divide is based on the nature of the antibody. And if the antibody is IgM, we call it cold autoimmune hemolytic anemia. If it's IgG, we call it warm. That's slightly imprecise. Cold and warm refer to the optimal temperature at which the antibody attacks and destroys the membrane. And most IgG antibodies are warm and most IgG antibodies are cold. In some instances, you can actually get both IgG and IgM in what's called mixed autoimmune hemolytic anemia. And even less commonly, you can have an autoimmune hemolytic anemia from an antibody called the Donath-Ladsteiner DL antibody that causes paroxysmal cold hemoglobinuria, which is a very rare autoimmune hemolytic anemia, more commonly seen in kids, which will hopefully bring a smile to Drew. But there it is. You got to have Drew smile on a Saturday morning, otherwise it's not a complete VMR. But the odds are warm autoimmune hemolytic anemia is more common than cold. The progress that we make is by studying the accompanying features before we get the Coombs back. And the accompanying features are warm autoimmune hemolytic anemia is simply more acute and more severe. Cold autoimmune hemolytic anemia is typically much more chronic and much more long-standing and punctuated by episodes of hemolytic crisis. So here, the Coombs test will tell you. The Coombs test will tell you if it's IgG or if it's C3. IgM, when you measure the IgM, when you try to test for IgM antibodies, you're testing in a warm test tube. So the IgM dissociates because it's a cold antibody, leaving the evidence of what it's done. So you'll never really see IgM positive on a Coombs test. The reason that is you're doing it in a warm test tube. So the cold antibody is not active. but you'll see the remnants of its activity through deposition of complement. And so here, I think the question to Gabrielle is, was the Coombs positive for IgG or was it positive for C3 or both? And that will help us make more progress. So Gabrielle, do you know the answer to that?
For C3.
Terrific. So we're in the much less common category of cold autoimmune hemolytic anemia, which I'll share with you in just 1 second. Oh, amazing. Here, I'll show you something a little bit more specific. 1 sec. I'm almost there, my friends. Here you go. So we are here. We are in the world of cold autoimmune hemolytic anemia. So these are the three these are the four. Warm is much more common. 80% of autoimmune hemolytic anemia is warm and cold is only 20%. And these are rare, mixed and paroxysmal cold hemoglobinuria. But we are here. And as we alluded to, the presentation, as Gabrielle is reminding us, is more chronic than it is acute on chronic. And the DAT, or the direct Coombs test, is positive for C3. We see rouleau, but serosites are actually much less common. And the causes are idiopathic in 50% and secondary in another 50%. And the most common cause of secondary is a monoclonal IgM-related disease process. But given the shortness of breath, I think you have to think about mycoplasma, as people have alluded in the chat, or other diseases. I'm looking and scrolling in the chat, and there are a lot of amazing tips. Gurbani, do you want to tell us how you use that mnemonic to help you remember?
Oh, no, it's silly. It's just that Maine is like the closest to the ocean on the East Coast and very cold. So I remember that one is cold.
Amazing. And to keep the multilingual mnemonics going, as Connie alluded to. Nalayan, how do you remember it in Hindi?
Hello. Yeah,
Hello.
So in Hindi, the word hot literally translates to garam, and the first letter of garam is G. So that's how I remember IgG for warm antibody.
Amazing. I think all of us should remember it as the following: garam for IgG and main for IgM, across cultural, international mnemonic. All right. I'm scrolling the chat to see. I will scroll the chat to see if anyone has any final thoughts, but keep thinking. We'll pass the mic for the sake of time to Gabrielle to take us home.
All right. So the M protein was positive. It was IgM kappa positive. The C3 was 48, which was low. The C4 was 5.4, which was low. And the folate was 4 nanograms per milliliter, which was normal but a bit low. The vitamin B12 was 102 picograms per milliliter, which was low. The final diagnosis was cold agglutinin hemolytic anemia, as you guys said in the chat. But I must admit that I didn't see this patient in the first time when she presented to the ER. But when she was on the follow-up, and they diagnosed her sarcoma of the ovary. And it was interesting because I didn't know at first when these diseases, these hemolytic anemias, that sometimes it can be a manifestation of a paraneoplastic syndrome of solid tumors, which is rare, but it can happen. And it was sadly for the patient because sarcoma malignancies, especially in the ovary, are of poor prognosis, and she's recovering from it.
I'm so sorry to hear that, Gabrielle. And I think that it's something that's so easy to overlook. And because you presented this incredible case, I'll remind you, when you're thinking about, oh, geez, 1 sec. I closed it. We don't think about this very often, but I think you have to think about this. In cold disease, the most morbid possibility is this. It really is. Pretty well described and pretty scary, and usually portends not the best prognosis, which is unfortunate for your patient, but a great reminder for all of us. So thank you for bringing it here.
Thank you guys for all the knowledge you shared with the chat. I learned a lot during this session.
Yeah, thank you again. You always bring the most magical cases, and I will note that this is not an infectious disease case. The first time that I've ever been around with you not presenting an ID one. So thank you so much for doing that. Valeria, do you have any reflections on what that feels like to have seen something and then be able to recognize it again much quicker? Just share with us your experience, because you were on the right trail from moment one, and I'm curious what we can learn from that instinct.
Yes, I mean, I really don't know. I mean, I feel like pattern recognition is not, I mean, as everyone says, and the really good book about thinking fast and slow says, that's thinking fast, kind of remembering what you have seen before. But I really have learned a lot because I just said it. I mean, a lot of people had mentioned a lot of really good diagnoses in the chat, and I just remember that case. And I think it would have been better if maybe I had come up with it just with the fact that the patient had really remarkable anemia symptoms, like the weakness and the dyspnea. And I really have learned a lot, and I will consider the paraneoplastic manifestation in my differential from now on. So thank you.
Your humility is unmatched, my friend. You recognize this from moment one, but here you are finding a place for you to even grow and grow, and that's true for all of us. Well, it's a delight as always to hang with you guys, and we'll pass the mic to Sukriti to reflect on the teaching today.
Hi everyone. This was a really nice case. Thank you, Gabrielle, once again. So when I started writing my teaching points, I couldn't help but put everyone's contribution, because I felt like the group made such a interesting contribution when thinking about this necrotic distal lesion. I tried to highlight as many people as I could. I'm sorry if I missed out anybody. So right off the bat, Chiara, reiterating what Valeria said about fast thinking, Chiara thought of Berger's syndrome. And then Hans layered this on, he layered this discussion on by saying that he was thinking about a bacterial infection and whether an infection was causing this single digit necrosis. Valeria very early on identified this as a peripheral vascular disease, like a cold agglutinin disease. And Kirtan took a step back. He wanted to zoom out and break down the complaint anatomically. So he divided this into whether this was a problem with the vessel or whether it was a problem with the blood. And Kanu then reminded us that he wanted to pause and think about what can mimic vasculitis. And there's an amazing schema on the CP Solvers app where you can see the differential for mimickers of vasculitis. So broadly, this falls into 4 buckets: infection, cancer, autoimmune, and vasculopathy. And then Rabi sort of summarized everybody's thoughts and told us his approach, where he thought about ischemia versus necrosis, and how ischemia almost always implied necrosis, but necrosis may or may not imply ischemia. So it's important to think about what are the causes of non-ischemic necrosis. And we broke that down into 3 buckets, essentially: infections, an autoimmune disease like pyoderma gangrenosum, and infiltrative tumors. We then decided to stop, and before we anchored any further, apply the law of proportionality. The law of proportionality essentially says, does the pathology explain the severity of symptoms? So in this patient, the distal necrosis, though suggested ischemia, the selective involvement with sparing of other fingers didn't. And as we got more information and we were told that this patient also had noted blue discoloration of her finger, Igor reminded us that blue discoloration favored something like a Raynaud's syndrome, and he thought about the existence of an underlying autoimmune disease. But right now on our differential, we were considering ischemia more strongly again because of this blue discoloration, and then thinking about whether there was a problem with the lumen or whether there was a problem with the wall. We also used the same concept of law of proportionality later in the case when we thought about this anemia, which really turned out to be the pivot of the case, where Arabi told us that anemia of chronic disease rarely presents with a hemoglobin of less than 9. So to really think about to think about another etiology. And then as we went on with the case, we were brainstorming about what could be the other etiologies, and we talked about Levy-Mesol-induced vasculitis, which is the primary cutaneous vasculitis with acral propensity reported with inhaled cocaine. And something that I learned today was Levy-Mesol-induced vasculitis is accompanied by neutropenia and high P-ANCA levels on labs. So broadly, we can summarize this whole case as a syndrome X, which was rooted in anemia, thrombosis, and splenomegaly. And Ravi encouraged us to think about how we could connect the anemia and thrombosis. And we came up with a lot of differentials like MAHA, PNH, APLS, sickle cell, and cold agglutinin. And Maria taught us that the Coombs test and spherocyte increase the likelihood of autoimmune disease. So finally, we all came up with an illness script for autoimmune hemolytic disease, essentially breaking it down into 4 buckets: the cold, the warm, the mixed, and the paroxysmal cold. We learned that warm is more severe and acute, while cold is long-standing and punctuated by episodes. And while thinking about warm, warm is essentially is either idiopathic or secondary, and the most likely etiology in a secondary cause is MGUS, which often has a chronic cause. But given that this patient had lung involvement and was acute, we were also thinking about mycoplasma infection. And finally, because this was a global warming report, and we were talking about languages. So Gurbani taught us that M is main, and that's how she remembers cold hemolytic anemia. And Nilayan taught us that hot in Hindi is garam, and that reminds him of warm hemolytic anemia. Thank you, everyone. I hope you had a great time.
Oh, did you see how she did that? Can you imagine? Not only did she track everybody who made their contribution, put it into a story that she like absorbed and processed and put out in real time. I think that was absolutely amazing and a delight. And I don't know, I would not be able to keep track of the individual words that people said and put them into a narrative and concocted in real time. So Kriti, that was magical. In fact, yes, I was tweeting in real time, tweeting about the magic that happened today. And thank you for summarizing it so well. All right, I'll hope to see you around any day this whole week, but in particular next Saturday where we all get to hang out again. Have a wonderful weekend.
Bye, everybody. Mic drop. Sukriti, that was awesome.
Hi, guys.